the recording over. And if it happens to show up live, all the better. Good afternoon, Endometriosis Summit family. For those of you attending on our Zoom link, either from Instagram, Facebook, Twitter, or now TikTok, actually, Dr. Arrington, I could see you having a good TikTok career. You should talk to the Center for Endometriosis Care. You would be very fun. In fact, I have a video of you dancing already. Anyway, if you have questions, you can put your hand up, or you can put them in the chat and we will try to get to them. Otherwise, please welcome Dr. Jeff Arrington. Dr. Jeff Arrington comes to us from the Center for Endometriosis Care in Atlanta, Georgia. And how many years have you been an excision specialist in endometriosis, Dr. Arrington?
Right now, about 15 years. Finished my fellowship in 2005.
Yeah, so lots of experience. And then joining us, of course, is the second half of the Endometriosis Summit. And we have Dr. Andrea Vidali, who is joining us from his makeshift studio in New York. And also, it is robotic heaven here, right? Both of you robotics guys, correct?
Yes.
Yes.
Sorry, guys, I'm trying to activate my AirPods, but I can't see. I don't seem to be able to do that.
All right.
Yes.
So we're going to get right into it. Dr. Arrington, what is endometriosis? What is the correct definition of endometriosis? And why does the language that we choose to use when defining the disease matter?
So correct definition are cells that are similar but not identical to normal endometrial cells, those cells that grow on the inner lining of the uterus. That are implanted by definition, they are found outside of the uterus. And that simple definition becomes critical, one, when we consider the treatment options. Well, I guess both considering treatment options and how we approach the disease. If we can determine that those cells are similar but they are not identical, then we have to be very careful when we start to tell people that those cells are from retrograde menstruation. Unless there's some sort of, histological, biochemical, or structural change in those cells as they pass out of the fallopian tube, if they're not identical, then for me it's hard to say that they came from inside the uterus. And it really points toward how the disease is approached. And I think in the mainstream OBGYN world, I think we've become accustomed to telling ourselves that our failures are more due to this disease just reseeding itself over and over, and really not taking the responsibility that could this be us? Could this be how I'm approaching the disease? Could it be how I'm treating the disease? If I can just blame it on retrograde menstruation and the disease always comes back. The flip side of that too, though, is that in one of the other treatment options, and I'm sure we'll get into this later with the definitive treatment of that's part of the justification that most doctors use to removing the uterus, that if we just remove the uterus, somehow it magically gets rid of the endometriosis because they've taken away the source or their perceived source of the disease.
Now, I believe that it's on the Center for Endometriosis Care's website, but it may have been ERC, but there is an article of someone who was born without a uterus that had endometriosis. Have you read that case study, Dr. Arrington?
I have not, but I mean, I've heard of those case studies and those presentations, both without a uterus. We know that it can be, or it has been found in males. That's just something that we know and we're aware of. Certainly within a disease, there can be different outliers or different presentations. And it wouldn't surprise me that all the different presentations of endometriosis that we see very well could be variations of the same disease, although, some differences in how the disease behaves or progresses. But clearly we know that the disease can be found in those without a uterus.
How often, Dr. Vidali, and you and Dr. Arrington are both what I would say uber specialists, big high-level specialists at big clinics that only see endometriosis. How often, Dr. Vidali, do you see post-hysterectomy endometriosis? And does that make you believe that the disease is definitely not from retrograde menstruation?
Look, I don't think that you could base it. I mean, I think the theme of hysterectomy is a big one. First of all, you know, when the big sort of misunderstanding about the treatment of endometriosis, I think one of the big ones is that doctors sometimes will go and just do a hysterectomy as like the first line of treatment or something like that. And that's certainly a problem. You know, I know that one of the mantras is that hysterectomy is not a cure. And that comes from the, you know, obviously, so let me just kind of like, sorry, let me just start and by answering your question. The first one, we do see endometriosis after hysterectomy, okay? But in fact, those are some of the worst cases because obviously having done a hysterectomy, the anatomy changes drastically. But the endometriosis is there probably because it was left there from a prior surgery where they just took out the uterus and left the endometriosis behind. So, you know, I don't want to be too verbose about it, but, you know, that's certainly a problem. And I think it's one of the themes that have to be debated, whether or not hysterectomy should really ever be considered as a first line of treatment for endometriosis. You know, in my mind, no. You know, obviously everything is on a case-by-case basis, and you're always going to find an exception. But as a general rule, I do not think that hysterectomy should be like a first line of treatment for endometriosis, period. I don't know how you feel about that, Jeff.
Certainly first line treatment for the disease, but even, you know, second line where, again, I'm preparing an editorial that I want to submit to the Green Journal. I won't go into too much detail with that.
Oh, tell us, of course, that's what we're here for.
No, I'm not going to go into details with that, but it starts off with a case presentation of a 21-year-old patient. Well, I saw her at 23. She had 2 prior surgeries in her teens for endometriosis. And then when she presented to her gynecologist at 21 with continued pain, in the gynecologist history and physical, as she describes the options, she quotes ACOG that the ACOG suggests that the definitive treatment for endometriosis is hysterectomy. This patient had a hysterectomy at the age of 21 based off ACOG's recommendations. And then when I got in there at 23, she ended up having rectovaginal, rectal, and widespread endometriosis that just was not touched. So clearly, just moving to hysterectomy or using hysterectomy to treat endometriosis is the wrong approach. The primary focus of any surgery for endometriosis needs to be removal of the disease, and then we can talk with the patient about what other appropriate procedures might be reasonable to consider. I don't want to gross people out too much, Sally, but can I hold up a picture on my phone about the largest single area of endometriosis I've ever removed?
Absolutely.
And this was in a lady in her late 50s that had had a hysterectomy 20 years prior.
You have it on your screen.
No problem?
Yeah, no problem. Also being on Zoom, we can do whatever we want. Yeah.
So nearly 10 centimeter mass, full thickness vaginal, rectovaginal, and rectal endo. This is in a lady who is 20 years after her hysterectomy for endometriosis.
So can you hold it back up? I just want to say something to those of us watching. Sometimes so you can see, because we're going to put the recording everywhere, you can see if somebody has a rectovaginal nodule like this, what did taking the uterus do for this? And what was her life like by the time she got to you, Dr. Arrington?
Mostly just debilitating pain. She had pain with bowel movement. She actually had full thickness vaginal disease. And so bleeding after intercourse, all those things that you would expect with that. So removing her uterus, they completely left all the vaginal disease, the rectal disease, the rectovaginal, as well as all the pelvic side wall.
So I'm going to give you each a chance to answer.
We see that far too often where the focus is, because that's what we're taught. Most destructive. Yeah. But that, to me, that is the most destructive word and dangerous word in their whole document, is that word definitive describing hysterectomy, because it implies something that cannot be given by just doing a hysterectomy.
Right, so we're going to get to ACOG standard of care in just a few minutes, but I wanted to set us up pretty well. I'll let Dr. Vidali answer and then Dr. Arrington answer. What do you think the myth of retrograde menstruation causes for the burden of society, the burden of the endometriosis community? How do you think that that has changed the endometriosis community? Let's start with that, and then we'll start with the standards of care.
Well, what I think that in a way it helped unite the endometriosis community, because I feel that it was one of those areas where you could see how people who were aware and are in the know were able to understand how these concepts were obsolete and unproven. So in a way, I feel that the myth of retrograde menstruation it was a unifier in a way for patients, because it helped people understand a lot of the misinformation that goes around with endometriosis. So I think that's one thing that, in a way, it helped us understand things better. I think if you don't understand the disease, and many doctors don't do that, and many practitioners don't understand that, then you don't. It starts from the very basics. So I think in a way it was helpful to know that there are certain ideas and sort of fundamental concepts that we can rally around.
Dr. Arrington, what do you think that this myth of retrograde menstruation, how do you think that changes the endometriosis community?
Sorry, what was that again?
What do you think, how do you think the myth of retrograde menstruation burdens the endometriosis community?
For me, I mean, it came about because of how it came about. And I think for me, it initially was just an easy way to explain it. Initially, as you look at it, it makes sense that that would be the most logical thing that would happen. But then hanging our hats on that and not ever being willing to look into it more in depth, it just ingrains us in what probably is not the case in the majority of patients. And by doing that, when you get into those who don't really study or stay up to date on endometriosis, you look at providers when they talk to their patients and say, look, we can go in and do surgery, but it's just going to come back. So why even bother? And it gives them an excuse not only to not operate or not to appropriately treat the disease, but it also gives them an excuse to explain why the disease is always there and why the patient keeps coming back. And I think it really puts patients in a role to where there literally is no hope. We all hear of patients who are told by their provider, look, I went in and removed the endometriosis, but we'll just have, we'll have to probably come back every year or two. And that really puts you in a state where there is zero hope. So not only do you continue in pain, but you're in pain and then realize in the back of your mind that this is just going to have to happen every year or two.
Yeah.
There are some questions from the participants. Do you want?
We're not going to do questions right now.
Okay.
They can ask them. We usually do them at the end, Dr. Vidali.
All right, just saying. I mean, there are some interesting one. I just
one of the things. How do you think that perpetuating the myth of retrograde menstruation impacts care? Dr. Arrington.
Again, I think that it impacts care. Number one, if you believe in retrograde menstruation, then your primary focus is going to be just on stopping the periods. And if that were true, if it was a retrograde menstruation, stopping the periods does not do anything for the disease that is already present. The only thing that would do is prevent new disease from forming. But when we consider retrograde menstruation, most of the doctors just think, well, hey, if I stop the periods, then we're good. I don't have to do anything else. And then you can carry in that beyond when the hormones don't work and stopping the periods don't work. The next step logically becomes removing the uterus, because that's going to stop the periods for sure. I've always said, before jumping to the uterus, if your goal is to stop the periods, why not just block the tubes? Why not tie the tubes instead of putting a patient through a hysterectomy? That's one of those common sense issues that common sense is lacking in endometriosis care for the most part.
Can you believe when I was the first year my private practice was open, so at most 12 years ago, I stood at a major pelvic pain conference, and they talked about how in order to stop endometriosis, you just use the robot to tie off the tube. There was no discussion of what to do with the disease. Oh, and then the pain that they have left after you've tied off the tube. This isn't that long ago. The pain that they have left after you've tied off the tube, that's just pelvic pain, and you can treat that as a pelvic pain practitioner. That's when I stopped going to the pelvic pain conferences. I just want to ask Dr. Arrington, you know, when we talk about retrograde menstruation and the burden it has for society, we have lots of Canadian listeners and watchers on tonight. What is this theory that nobody questions due to access to care in countries where maybe excision isn't as advanced? It's just taken at face value that it's the period. How do people in those countries access care better?
I mean, it's tough. I mean, your access is not only limited by knowledge, but it is limited by availability and what's around and what's near. And I mean, you can educate a provider. I mean, ideally, we could educate providers very easily. That's just sharing of information. But to get a surgeon or a doctor to the point where they can adequately treat endometriosis is clearly not an overnight change. Education in that point would really point toward a referral-based approach rather than just magically making someone an endometriosis surgeon. So clearly limited by educating the doctors and what they understand, but also limited by resources as well.
So you both in the past
It's
year,
tough.
yeah, it's very tough. I know I speak to Nancy Peterson a lot. Nancy has a lot of heart for what's going on with Canada and excision. And because it's such a stronghold that I see a little different, maybe you two just haven't gone there. If they believe it's just retrograde menstruation as a society, then they're going to push drugs like birth control pills or Lupron or even Orlissa on the people there, because after all, it's just about stopping the periods. We can get into that. But I wanted to ask, both of you in the past year have given two very different presentations, but you both have talked about pain in the endometriosis community. Dr. Vidali, I know that you believe that there are multiple generators of pain and there are multiple sources, that it's not just oftentimes only from the lesion, that there could be an underlying autoimmune cause to pain. Can you talk to us a little bit about that? And then I'm going to hear all about how Dr. Arrington thinks pain plays a role in the body. So first, Dr. Vidali.
The way I see it, and I think it's panning out to be, as you know, there are some patients who have extensive disease and relatively few symptoms, and then there are patients who have less disease and significant symptoms. So there's different degrees of sensitivity to the same insult. I mean, the insult is the same: inflammation, scar tissue, but the response is not the same to the insult. So clearly, you know, the insult itself alone, which is the presence of the endometriosis, is not sufficient to create like a significant symptoms. What you need to have is the insult plus some sort of a predisposition, which may be genetic in nature, to have, you know, to use a simplistic term would be more sensitive nerves, but I think it relates more to how, you know, your inflammatory response is going to be to the insult. You know, to make a comparison, we're in COVID times, and it looks like the patients who are the sickest are the ones who have the strongest response to the virus. So some people have it and they have nothing, no symptoms, and others have these massive pneumonias, which are, you know, they're generated by an excessive immune response. So I think it's certainly worth investigating further. And, you know, we're looking into this, but it's just like, obviously, you know, superficial look, because, you know, these are kind of novel concepts, but that there could be a predisposition to develop sort of like more significant neurologic symptoms. One of them is being pain. And this is one of the reasons why we also see patients with severe endometriosis symptoms sometimes have associated, and remember, association is not causation, associated other syndromes like chronic fatigue or fibromyalgia or other autoimmune conditions. By this, I don't mean that, people always ask me, is endometriosis an autoimmune condition? No, that's not how we look at it. Endometriosis, ultimately, it's an inflammatory condition. The treatment is the same, regardless of what it is, the treatment is to remove it. That's accepted conceptually and proven. But the way you respond to it and your natural predisposition to it is that. And I think that's one area where we have to study more and learn more, and maybe one area that we have to develop in our endometriosis summit, something we could look into deeper, because I know there's a lot of interest on part of patients about this sort of autoimmunity and endometriosis link.
Dr. Arrington, late last year, you gave an amazing lecture on how endometriosis contributes to pain. And again, we've seen those cases where the person has deeply invasive disease and doesn't have any pain. What does endometriosis do to cause pain? I could ask a very specific question, but I'll keep it broader because not everybody out there is a pelvic PT.
Yeah, so getting down to just the basics of patients are not going to feel pain unless that pain nerve or pain neuron is fired or becomes unstable. So there has to be some sort of insult, and typically in endometriosis, it's going to be inflammation. Inflammation is a major pain trigger in the body and destabilizes the neurons. And that starts the pathway, the feedback pathway back to the brain to say, hey, I hurt here. So as those nerves are triggered, whether it's inflammation or scarring, anything that destabilizes that nerve has the potential of sending a signal back to the brain to say, hey, something is going on here. There's a mechanical insult or an inflammatory insult that is painful to me. So, there's the physiology of how the pain nerves work and all the different inflammatory mediators and what they would call it an inflammatory soup that triggers those. That all results to a signal back to the spinal cord, and then it's up to the spinal cord to transmit that up to areas in the brain that recognize and feel the pain. Along with that, I think an important factor of pain, really, we have to pull in what is a patient's past experience. A patient's past experience is also going to dictate how they feel their pain. That if someone is chronically painful and they feel pain in a really significant way, their bodies and their minds are going to be hypersensitive to those painful stimuli, maybe more so than someone who's not. We look at patients, and I shared this in my talk, that we look at patients here post-surgical for endometriosis surgery, for hysterectomy, and the difficulty we have here, at least in the United States, of managing post-operative pain. And then when I was in my original practice, I had some colleagues that would go over to Mali and do medical missions over there. And they would have patients walk miles and miles and miles to come in, and they would have a hysterectomy, most of them for big fibroids, heavy bleeding and all that. They would let them recover overnight. They would give them one Lortab, and then those patients would walk miles and miles and miles back and never complain. Pain would not limit them. And I think that clearly there is a societal component to that, but I think more than that, it's just a patient's experience and how that impacts how they feel pain. As far as that, central sensitization is becoming a big thing. And really that takes place at the dorsal ganglia in the spinal cord, where those nerve cells can become upregulated and chronically fire if we do not take care of the distal or peripheral pain insult. The longer that pain stimulus feeds into the spinal cord, the higher the probability that is going to be chronically triggered. And we not only see that in endometriosis, but we see that in patients that have distal peripheral nerve impingements. The longer that is in place, the higher the probability that they'll end up with a chronic radiculopathy.
I think it was very interesting that you pointed out that there's an initial mechanical insult, and then that message gets translated through the spinal cord. I have seen it work some other way. So in our world, Dr. Vidali, Dr. Arrington, certainly the rest of the Center for Endometriosis Care and the rest of the excisionists, we believe in removing the mechanical insult. I have seen it in the pelvic physical therapy and the pelvic pain world. Well, because that signal is still going to be there, why bother to remove the mechanical insult? So once and for all, Dr. Arrington, why bother to remove the mechanical insult?
So whether it's mechanical or inflammatory, whatever, we call it a noxious stimulus, the longer that's there, the longer it's uncontrolled, the longer that is going to be stimulating the nerve. And then the longer that, the peripheral, the insult out here, it transmits into the spinal column, the longer that signal is going, the higher the risk that that central neuron is going to be chronically triggered. And then in the endometriosis world too,
also, Sally, if you have a thumbtack on your foot, why would you not remove the thumbtack from your foot? You could step on a thumbtack. I mean, that's just
right. Well, we all see things the same way. The other thing is I see it this way, that it creates an inflammatory soup, and that inflammatory soup affects a lot of your body, from your hormones to your fertility. What does leaving that mechanical insult inside of the pelvis do for the fertility, Dr. Vidali?
Fertility-wise?
Yeah.
Well, first of all, it's not a mechanical, like I said, it's an inflammatory, endometriosis is an inflammatory condition. So whenever you have alterations in your inflammatory profile, that will affect implantation. It's inevitable, because implantation is a major immunological event, because the body, like the body has to accept the pregnancy and not reject it. And an activated inflammatory system is more likely to, and I'm saying this in very simplistic terms, obviously, for everybody to understand, but is more likely to reject the pregnancy. So these are the basics of basically the basic concept of how endometriosis reduces fertility, and that which goes beyond the classic understanding, which are adhesions, blocked tubes, which it goes beyond the obvious. So you have to remove this inflammatory component, which we do see when we do testing in these people. And so ultimately, that's really the goal. The goal of the surgery is to remove the inflammatory insult that sort of raises the overall inflammation on the body. And we see this we see this serologically in activation in certain groups of cytokine producing cells, and especially the interleukin-17 producing cells. So it's something that we see, and we know it's connected to the presence of endometriosis. And that is the mechanism. Of course, it's a lot more complicated than that, but conceptually, you understand what I'm talking about.
So Dr. Arrington, suspending what we believe, in some ways, how would, and just be honest, because that's what we brought you here for, how do you think something like, say, birth control pills would affect that inflammatory pain mechanism? Uh-oh.
Can you hear us?
Do you hear us, Dr. Arrington? Oh no, it was such a good question.
I think the idea behind
that was a good question. Yes.
Pills and any hormone is that it most likely it probably does decrease. Yeah, am I blocked off on your end?
I don't know. It was such
Hello?
a good question.
Hello, can you hear me?
Yeah, we can hear you.
Can you hear me? Can you hear me?
Yeah. Yeah, we can hear you.
Okay, I've just got frozen video on here. There we go. So so birth control and the inflammation. The reality is there probably is some inflammatory prevention effect to stabilizing those cells. So using birth control, using a progesterone, something that stabilizes those cells, may prevent the inflammatory cycling that we see with them. And I think that's part of the rationale behind why we do see some improved pain in certain patients when they're on those simple hormones. That's one of the really that's the only role of birth control and hormones, is to help with the pain, and that likely comes from limiting the inflammatory response of those cells. But as far as I am aware, and ACOG even admits this, is there's no evidence that any of these hormones prevent progression of the disease. So even though we may be improving the pain aspect of it, I think improving pain and actually treating or preventing disease are two completely different goals.
And what is, using the same thought, what is the mechanism or the thought behind using some of the other drugs like Lupron or Lissa to attend to this? And what are those drugs, by the way, just in case anyone out there doesn't know?
I lump them all together as GnRH modulator drugs, gonadotropin releasing hormone modulating drugs. In my mind, all of these hormones, whether it's birth control, progesterones, Lupron, or Lissa, they are all alternative pathway pain medications when it comes to endometriosis. But the GnRH modulators work on the pituitary gland in the brain, with the idea that Lupron ultimately decreases the GnRH output, and then Lissa actually directly blocks that gonadotropin releasing hormone, and that will put a patient into menopause. That feeds in and shuts the ovaries down, so the ovaries will no longer cycle and produce estrogen. So the idea behind all of these medicines is to put a patient in a estrogen deficient state, with the idea that, most likely it's probably because everybody believes that stopping menstruation is going to stop the endo. But the reality is we probably see improvement in pain with some of these medications because it does limit the inflammation associated with the disease.
And what's your opinion, both of you, on that standard of care that says we should be trying those medications before excision? Dr. Vidali, what do you think about that?
Well, obviously, it's not a very good recommendation. First of all, because you don't know who you're treating. That's the first one. We never treat conditions unless we have a diagnosis. You don't do that. And there are many instances where the presence of endometriosis, although suspected clinically, is not visible or identifiable with any study, whether it's ultrasound, whether it's MRI or any other study. So the idea that you would blindly treat all these people with very powerful medications which have a lot of side effects I don't think is acceptable, mostly because you would end up treating a lot of people who actually don't need it. So that's a bad idea. So the first step is actually proper diagnosis. But because the only valuable diagnostic act is the laparoscopy, why would somebody just do a diagnostic laparoscopy and not treat it? So obviously it is not a good idea to, and the second part of it, and Jeff will probably agree with me, is that endometriosis is a condition that, although it's diagnosed late because of inadequacy in our healthcare system, it affects young people. So we really don't have any treatment, even these treatments like Lupron and Lissa, which we don't commonly recommend because of their side effects and their inadequacy and risks. They're even people who promote them, they don't recommend them as long-term treatments anyway. At best, they're a short-term solution. So given that, it would be absurd to actually subject people to these treatments right off the bat without proper diagnosis and potential treatment.
Dr. Arrington?
Yes, I made a couple notes while he was talking that I want to cover, but I mean, you mentioned the role of the diagnostic scope. Really, as far as purely diagnostic laparoscopy, there is zero value in that unless it is used to dictate then a referral. It makes zero sense to have a plan of a patient where I've had you on these hormones, let's do a diagnostic scope and then come back and place you on the same hormones that we've already tried. Zero value in that. One of the main risks that I see with the Lupron and the Orilissa is we are seeing this more and more significantly now with Orilissa, that's the favorite new candy on the shelf of GYNs. And we're seeing that used in young women, in teens, in patients in their early 20s that are at the most critical time in their life for building bone density that needs to carry them all the way into the later years of life. And during the time that they're on the Lupron, that they're on the Orilissa, we are limiting their bone growth that will affect them the entire rest of their lives. We know that's true with Lupron, and we suspect that it'll probably tease out that way with Orilissa as well. The other thing, and I am very, very critical about the ACOG document, but one thing that I see in there in a couple instances is there are statements that are hidden inside that document that regular OBGYNs have no clue that those statements are even there. And one of those falls into the category of the equivalency between birth control pills and Lupron. We often hear insurers talk about this, doctors talk about this. It's often presented that birth control is the initial phase or initial tier, and then we can go to a progesterone only as a tier, and then the third tier, the ultimate, are the Lupron and the Orilissa. But if you look at these medicines, the Lupron and the Orilissa, and compare the Lupron head to head with a birth control pill, the only role of controlling pain, they are equivalent. And they've done head-to-head studies between Lupron and pills, Lupron and Mirena, and they are equivalent at controlling pain. One is not better than the other. And just a couple weeks ago, I ran into a study that was looking at Orilissa and Depo-Provera. The primary focus of the study was bone loss. But a secondary finding in that study is that Orilissa did not control pain any better than the Depo-Provera did.
That was the initial study, by the way. That was the phase 1. That was the phase 2 study of Orilissa. Okay. Taylor. Yeah.
But I mean, this is one of those things where they're presented as second and third tier medications, but they are only second and third in the cost and the side effects of those medications. They are not second and third tier in the response, in the pain improvement and response to the patient. The only other thing that really bothers me about these is, again, all of the hormones really, from birth control all the way up to the Lupron, is they're meant to control pain. They completely ignore the possibility of progression of the disease. That Dr. Cernervo calls it hormone shopping, where they go from one to the other when none of them work, and they're exchanging medicines between equivalent drugs as far as controlling the pain goes. We say that the Lupron and the Orilissa, those things are standard of care second tier. But in that ACOG document, they state that the initial trial of birth control pills is reasonable, and I don't disagree with that strongly. But then they do mention in there that if a patient fails the initial trial of hormone therapy, that surgery may be considered. And that is one of those things that's written in there that doctors in training and residency programs completely skip over and ignore.
Why do you think that is?
It's because of how
nobody knows how to do good endosurgery.
Yeah.
Go ahead, Jeff.
Right.
Yeah. No, you go ahead, Andrea.
No, please. It's your show.
Okay, please. What have you
No, really, it's how we're trained. I mean, there's all of this stuff that's written. Again, most of the statements within the ACOG document that would support our position on this are really pretty well hidden in there. They form a very minute part of the entire article. But based off the training, number one, the doctors don't have the skill to number one, recognize endometriosis, and number two, excise the disease. So what are they going to pass on to their residents? They're going to pass on the knowledge that they have and the approach that they have. In my residency, it was put the camera in and do what we call the peek and shriek. If it's stage 4 endometriosis, you document it, you close up, and then you put the patient on Lupron. That's how we were taught. And it's a very, very slow transition to get the new doctors coming out to really approach this idea that this is a surgically managed disease, and it's very possible. And even in residency and training, we're taught that, oh, it's too risky to treat the bowel, it's too risky to treat the bladder, and we just throw out to our patients, I saw endometriosis on the bladder, but it's too risky to treat there, instead of saying, look, manage the appropriate way. These are what the actual risks are. Instead of blindly throwing out that it's too risky, to step back and understand that really bladder endometriosis doesn't carry all that much risk to remove. The bladder responds and heals very well. It's very forgiving. And same thing with bowel. They throw out the risk without really understanding the true nature of that risk.
I also think, sorry, Sally, from a training perspective, I feel that most training for residents in gynecology or anything is usually hospital based. And I think when you're in a hospital environment, you really don't see, you don't really have the effect of continuity. And I think a true understanding of the suffering of the patient with endometriosis comes from continuity of care. When you keep on seeing patients and they become your patients and you get to know what's going on with them and you really understand the depth of the problem. I think that a lot of resident training, when they are in a sort of like a clinic setting, their encounters with patients are very, there's no continuity. They see somebody, then somebody else sees them, then somebody else sees them. So I just don't think they really grasp it. I just don't think they have a deep understanding. And I think that it is kind of like a big problem, I think, in resident education, not just the surgical part of it, but actually an understanding of the severity of the condition. It's lacking, I think.
And where does that leave the patient? Right? We talked about the definition is wrong. The doctors are being taught maybe the easiest thing. There's no continuity in care. Residents aren't really well trained. Where's the patient in all that? Where does that leave the patient?
The patient has to become an advocate for herself. You have to advocate for yourself. And I think it's very important in medicine not to be passive. We always have to, the definition of patient implies passivity, right? You're patient, you're there, you're waiting, like you're somebody who's patiently waiting for, you can't be like that. You have to be an advocate if you're a patient, I think. And I think you have to be demanding. I think it's important to be demanding. And sometimes doctors get annoyed by the demanding patients because like, oh my God, it's a troublemaker, blah, blah, blah. But the reality is that I believe as a patient, you have to be demanding. I personally know that I am demanding when I am a patient, very demanding.
Dr. Arrington, what do you think the role is of the excisionist and the advanced specialists that are out there in challenging what is sort of this status quo in endometriosis right now?
Well, I think one of at least the way I perceive my role, one clearly is to educate patients as much as I can. Clearly educate on a local basis, an individual basis with doctors. Back in before I came to the CEC, I worked in a practice. There were 7 other OBGYNs, and they all knew what I did, and they knew how I approached the disease. And for the most part, most of them, if they got in and found a patient that had more disease than they expected, or she had a prior surgical history, then they would recognize that and refer. So individually helping doctors be aware of what's available, and then really sharing and educating on the true risks of appropriate excision. Beyond that, though, there are so few of us, not only to care for the number of patients, but in order for us to individually educate all these other doctors, it's nearly impossible. We have to have support from bigger organizations, that there has to be a recognition of this from bigger organizations that have the ear of the global or OBGYN community in each country or globally.
Yeah, I think it's going to take, right. I think it's going to take a couple of really noisy doctors sitting in a powerful position to mobilize a community like that. What role do you think a lot of those doctors that are in those positions their studies or whatever they're working on are funded by pharma, what role do you think that is going to play?
Well, you know, it's a concept of conflict of interest, right? You know, there's a reason why doctors, whenever they're giving a lecture and or a presentation or speaking in any public environment, have to disclose what their conflict of interest, because it is acknowledged that when you have a conflict of interest, it means that you may not tell the whole story, because your perspective is going to be biased by the money that's coming in your pocket from whatever company is sponsoring you. So, you know, and obviously we have rules where doctors have to say at the end, by the way, I'm giving this lecture, but I have a conflict of interest. But usually it's like written like that big, you know, it's like a very small thing. And by the way, very small. So I think one of the things that the community can do is highlight, guys, can we be quiet, please? Hello?
There's a lot of kids.
Sorry, guys. Yeah.
Yeah.
Shh. Sorry.
Dr. Arrington, what do you think that veil of pharma bias may do for progress in endometriosis?
You know, not only the conflict of interest, and that's something too. I think a lot of patients have the idea that doctors make money for every prescription that they write. And that at least as far as I know, that's not true. There are a number of doctors who are paid for the studies and paid to be speakers and paid because this hormone is successful. It's interesting that, you know, we have to disclose those conflicts of interest to other providers when we speak. But we aren't required to disclose those conflicts of interest when we're suggesting treatment options to our patients. To be fair, I have a conflict of interest with surgery. I mean, that's how I earn my living and what I'm able to do. And clearly, I try not to let it bias, but my bias is based off what I see with patients and how surgically managed patients can be. But there is some bias there as well. Now I totally got sidetracked and forgot the question.
But it's a good point, I think, you know, and I'm glad you made that point, Jeff. You know, it's a very good point, because obviously, you know, you're talking to surgeons, and of course, surgeons are going to talk about surgery, and there is such thing as cognitive bias, you know, and we cannot deny that's a reality. But, you know, I guess as doctors, we have to try to maintain intellectual honesty as well. And I think intellectual honesty is probably the most important asset for a doctor and for the reputation. But I'm glad you made that point, Jeff. It's very well taken.
Yeah, and I think, you know, the main thing for me is understanding that I probably do have some bias, but that just pushes me more to be honest about all the presentations. I give my patients, every one of them, a talk that I call ibuprofen to hysterectomy. And we go every step along that way and say, this is the role of this treatment. This is what's expected. These are the upsides. These are the downsides. And present that information to the patient, so that the patient then is allowed to make a decision based off information rather than what I'm putting, saying, oh, here, this is the newest, latest, and greatest drug. This will take care of your endometriosis. One other thing critical too, Sally, looking at the pharma influence on this, is we look at the whole research aspect of endometriosis. I don't know the direct percentages of research funds, but I would not be surprised that if we looked at all the research that is involving endometriosis, that the huge majority of that is pharma supported. And pharma supported surgery is going to meet their needs and their goals. They're going to do research that is going to promote their influence on the disease, as opposed to directly going in and doing basic science research to figure out the disease. They're going to be pushed more toward doing research that supports their position.
Exactly. And we see that a lot with the Endometriosis Summit in the companies that try to sponsor us, is that they want their own message, and I would love to see one day in the future a level playing field really evaluate the disease and what may or may not be the factors that cause it. But it's hard to fund that level playing field. Let's be honest, no one wants to work for free, but that becomes, you know, an issue. One day, Dr. Arrington, we'll have to have you on the summit to do your Advil or ibuprofen to hysterectomy talk. We have just about 15 minutes left. I wanted
Can I just say one more thing? Can I add one more thing? I think one problem that we have is that surgeons will say, look, I'm a practical surgeon. I'm a clinician. I do surgery. I treat this condition. I don't have time to do research. So, you know, one of the problems is that I think that excellent surgical centers have produced very little research. And, you know, I'm talking about solid, you know, research. And I think that's something that we all have to admit that it is an area that we ought to have to work on. And, you know, maybe
I think it's just so overwhelming to have there are so many patients and so few excisionists that the excisionist, it's hard for them to bear the burden of research as well. You know,
but we need to make an effort, you know, Sally. It's a limitation. Right. We have to do it.
Well, we'll all be working 7 days. I mean, now you guys are gonna, both of you are gonna be catching up for 2 months of missed work. And I think like we have to figure out how technology can work for us, whether it's databasing or something like that. We have just about 15 minutes left. I wanted to ask some questions from the crowd. Dr. Arrington, how do you treat somebody who is showing symptoms at 13, 14 years old? And the second half of that question is there any way, if the mother has it, to prevent that progression of symptoms for the child?
My typical approach for a patient in the teens, number one, really at least in my 15 years of doing this, the youngest patient I've ever seen with invasive rectal or invasive rectal vaginal disease has been in her late 20, or between 20 and 21. So taking that information, it's very unusual for me to see a patient who is in her teenage years who has what I call destructive endometriosis, to where it's starting to create inflammatory adhesions. It's starting to be deeply invasive into other organs or impact her fertility, potential fertility at that point. In that mind, I think it's fair to do an initial trial of birth control, but with the understanding, both the patient and the mom, that the goal of this medicine is to help you be functional, to help that patient to do what they want to do in school, to be active, to enjoy being a teenager. And if we don't accomplish that with the hormone, then our next step may have to be surgically going in and removing the disease. I do not think it's fair to make a 13 or 14-year-old wait because they're, quote, too young to have surgery. If the initial hormone palliation or hormone control of pain is not successful, then we need to do something that allows that patient to live her life or do the normal things they want to do.
Can all the inflammation at the lesion be blocked by, we get this in the PT study groups all the time, can you just do a diet and block all the inflammation and the disease will never progress?
I don't know if you want to answer, Jeff. I mean, but I'm going to just throw in my 2 cents, which is I deal with a lot of issues immunological related also for recurrent pregnancy loss, which is you're not going to cure a disease just with diet, okay? But I think that diet can help because by decreasing overall inflammation, you sort of help the peripheral, at the center, you can decrease the inflammation at the level of the peripheral problems. In fact, we do see a lot of patients that say, look, yes, with the diet, I try to go gluten-free and do an anti-inflammatory diet, and I feel a lot better. I'm still in pain and I still have problems, but things are better. But I think that I don't think that we can assert that you can actually cure the diseases of this magnitude purely with diet. And so I think it's very important to observe that. And certainly not by taking 100 supplements, sometimes one goes against the other.
I think while diet helps and it modulates symptoms, people don't realize how bad they feel until they don't feel bad anymore. And so it's the, you know, removing the disease at its root can be a huge change, just like what Dr. Arrington just said, where it's about living your life. You don't realize when you've had pain for a long time how much you've compromised your life. Like most of the people with endometriosis right now don't think COVID and staying inside is a huge change to their life, because they stay inside a lot anyway. And so I think we don't realize how much the disease impacts you until it's gone, because we've normalized that lifestyle for so much. Dr. Arrington, there's an interesting question in the Q&A. Why do we call endometriosis, we call them deposits or we call them lesions? Why do we not call them tumors like if it was cancer? And so I'm going to ask Dr. Arrington first, and then our immunological specialist may have a different answer.
You know, in true definition, they are tumors. One of the talks I remember from AGL a few years ago called endometriosis non-malignant, not benign. Depending on where, you know, how the tumor behaves. And again, this may be a difference in the actual diseases that we see in the spectrum of endometriosis. Clearly, there are endometriosis masses that are masses that we would consider tumors, and I describe them as masses or tumors. But because they don't typically metastasize or behave like a cancer, we don't call them, clearly they're not cancerous tumors, but they could be classified as tumors. The simple implants, superficial implants, those sorts of things, I don't know if really any of us would classify those as tumors. But more than anything, it's probably just semantics. But the surgery or the management itself very much is equally on par, or is on par with how we treat a lot of malignant tumors.
Dr. Vidali, you have any comments?
No, I think Jeff nailed it. I think he's right on with that. I agree 100%. And this is one of the reasons that I think a lot of doctors don't respect endometriosis, because it's not cancer, you know what I'm saying? And I think that's one of the problems, you know, I think I agree.
I have to say, from an advocate's perspective, and I understand the science really well, I do have medical license and a medical background. I don't like when we have to call endometriosis a benign cancer. This is not going to be a popular thing, but I don't like it because we don't have to make our disease something else to have it taken seriously. That, I feel, is our role as advocates, is to raise the level of awareness and the importance of our disease as a disease on its own. I don't need to tell everybody I have benign cancer because I need people to understand it. I need to teach them how to understand it without making it into something else. So I always have a thing, like, I know I miss him so much. We'll have to have Joe on one time. He loves to say it's a cancer without it being a cancer. I think he says that because it's everywhere in the body. And when cancer, he's a surgeon. So when cancer surgeons go in, they're prepared for multiple locations, and not enough GYNs are. I think that's why he says that. But for me, I don't like to elevate the name of it to make other people understand it. I want to teach them how to understand it. We have a very interesting question, and it goes back to that inflammatory soup we were talking about. And it asks, can anti-inflammatory drugs with less side effects that don't disrupt hormones be more effective in reducing pain after excision than we think they are?
I think that, I don't know if specifically after surgery, but in general, head-to-head, they tend to be fairly equivalent to hormones. And again, we're focusing only on pain management. We're not focusing on the entire patient, the entire disease. We're focusing purely on pain. Right after surgery, the initial pain is probably going to be more truly inflammatory because of all the raw surfaces. And in those cases, anti-inflammatories are initially better choices than hormones. Hormone is not going to stop surgical inflammation. Most likely they're going to be fairly, if they were studied head to head, it's probably going to be more in the equivalent range.
Excellent. So we have another question about research, because we have somebody who's working on one of the Department of Defense projects. Again, let's remember that endowhat.org helps solidify that funding from the Department of Defense for endometriosis research. How do surgeons look for basic research collaboration, and what are they looking for to achieve a comprehension of the disease, a cause of the disease, or what are you looking for to come from your research?
Maybe I'm going to bounce that to you, Jeff, because I know that you guys at the CEC are now collaborating with Dr. Ashine Fazel in France, doing some very interesting, you guys are involved in interesting project, I think. So, you know, maybe you want to talk a little bit about that. I was talking to Ashine last week, so I think it's important that you mentioned that project.
You know, I don't know specifics of the project. Typically, at least since I've been here, most of those run through Dr. Sinervo.
Yeah.
But I mean, in general, you know, the research that surgeons can participate in, clearly we could participate in how well we are doing surgically. Those are going to be more simple studies looking at outcomes, looking at repeat surgery outcomes. It's very difficult, I think, to document true recurrence or persistence of disease, but repeat surgery, how the patients do afterward. But there are a number of doctors too who are involved with, you know, genetic centers and things like that, who are collecting specimens for genetic research, trying to get down and really understand this disease on a cellular level and genetic level, to see if we can gain more understanding of it. So they may not be directly involved in the bench research, but providing specimens, providing patient histories, providing those resources that feed into those bench research projects to help understand the disease on a disease level.
Wonderful. I just want to point out, there are some people posting links to their own work in the comments. The Endometriosis Summit or the doctors involved here do not endorse and are not using this forum to advertise. So let's just finish up. Dr. Arrington, where would you like to see endometriosis go in the next, first of all, the next 3 months, but what direction would you like to see for endometriosis in the next year?
A year still in the management of endometriosis, I think, is still a very short time. And clearly we see this in all the years that people have been advocating for improved care. My personal goal, one of my things or themes for this year is really along the informed consent aspect as far as treatment goes. To really raise awareness with ACOG and with the members of the general OBGYN community that leaving excision out of the options when we're presenting these to patients is lack of an appropriate informed consent. That excision should be recognized as an appropriate treatment and therefore should be included in an informed consent, even if the provider is not able to provide the service. We never ever should limit our discussion of options with a patient based off what I can do myself. If there are other options that are out there, and we see that with cancer, we see it with prolapse, we see it with high-risk pregnancy, with every other aspect of OBGYN, we offer those patients a truly informed consent. That, for me, that's my main thing, is just to gain an acknowledgement that this is an appropriate treatment. And by understanding that it should be discussed and offered to patients, especially, you know, we talked in the beginning, especially before a 21-year-old has her uterus removed.
Yeah. Dr. Vidali, what would you like to see for the future of endometriosis?
Well, two things really. The first one is I'm looking forward to more collaborative work amongst different specialists. I know that we had a very interesting meeting this week with, you know, Dr. Sinervo, Dr. Gargiulo, Dr. Dulemba discussing collaborative efforts, and it was extremely interesting. And the other thing I would like to is expand our knowledge in the fertility, you know, which is kind of like my interest as well. You know, one of my interests, the connection between the immunological aspects of endometriosis and fertility. So those are my two areas that I would like to see developed more: collaborative and looking at the immunological connection with fertility.
Sally?
So what would I like to see? Well, first of all, we have officially moved our reproductive immunology conference from a New York-based conference in October to an online conference, which gives the patients more access. But what I would like to see overall is I would like to see us challenge the status quo by all being together in the same fight. So a unification that comes from education, and that comes from using one voice instead of being little separate communities that are all clawing for a piece of the pie. I think that the more unified that we are, the more we can chip away to make true change and to all get behind one voice. We could be multiple groups that are behind one voice, but that we should have a common goal in mind. And I like this live format because we don't filter any of our doctors. They all come on there. None of them are paid. And I think that some of this online community that is being built because we can't go places will only allow us to access more people. So a lot of you couldn't come. We may have to do the Endometriosis Summit in March online. So instead of 400 people, we could get 500,000 people, because everybody who has access, and we can set up access points where people can get it, will be able to listen instead of only those that can afford to come to Hoboken. So we're going to turn lemon.
To also mention the name of Dr. Mossbrucker, who's like really been one of the leaders in keeping it together. You know, I just want to thank her presence as well.
So, all right. I am excited to have all you here. The link for the recording should be on Facebook as soon as Zoom sends it to me. There is a researcher looking for the link directly. If you're looking for the link directly, you can reach out to me and I will send you the link. Dr. Arrington or Dr. Vidali, any parting thoughts?
Jeff?
Oh, you know, my thoughts are, again, I guess I've been known, I've always worked in the private sector through my whole career. I have not been in an academic center. I approach things as I see them from just a regular OBGYN out in the world practicing, and it really, and working with those patients. Again, in an academic center, it's very hard to follow patients through. So what I have learned, I've learned from my patients. And that's really opened my eyes to a lot of the deficiencies that really, I guess, for lack of a better way, push my buttons and get me involved, or trying to reach out to ACOG, trying to create change, really just being fair and trying to get what we can with patients to get them the appropriate care that they need, to have truth spoken to patients when they go to their doctor, to have a clear understanding of what their options are, to have a fairness with patients, but also to treat the patient as a whole patient. Endometriosis patients are not just pain patients. They're not just fertility patients. More often than not, they are both. They can be fertility patients who are in pain, and they can be pain patients who are impacted in every aspect of their lives, with work, with relationships, in every aspect. And it's too often that OBGYNs focus only on one aspect, either pain or fertility. And also, you know, and getting those OBGYNs out of their comfort zone and sitting down and listening to a patient. And instead of seeing a new patient come in who has already been struggling with the disease for 10 years, has been on every hormone, to actually listen to that patient's experience and not come back and just offer the same hormones that the patient's already been on, to sit down and realize that, hey, you've already been there. What more can we offer? What more can I do? And clearly just, my goal is to pick apart the things that are problems in how we set the standard of care, and really try to get those changed, raise awareness, and just get people to think, and in the OBGYN community, to use a little bit of common sense in what we're thinking about this disease.
Awesome. Parting thoughts, Dr. Vidali?
I just wanted to thank Dr. Arrington for his clarity and honesty. I think it's very rare to find doctors who are so honest and clear, which, you know, there are two qualities that are just very rare to find. So thank you, Jeff. Thank you very much for what you do.
Dr. Arrington, when we finally have a live summit again, we cannot wait to have you. We are on board and give you our support for all that you do to push the challenge with ACOG and with anywhere else. You know, push. I see you in the mixed group. I like to see how you want to make people think a little bit. We like to see that. We support you. I want to review with everybody just a couple of big events that are going on in the next couple of weeks. Tomorrow, we will be in a private webinar with just the GFAMers. So if you are GFAM, you can get access to Dr. Vidali and I having a discussion about endometriosis and Endometriosis Awareness Month, since we were rescheduled because of COVID. On April 20th at 8 p.m. Eastern Standard Time, we will have Rick Rosenfeld on, and along with a few others, to discuss what the marketplace and what the community of endometriosis is like for the younger, less established surgeons, and what it's really been like to develop a MIG specialty and excision talent. On Wednesday, April 22nd, to embrace Infertility Awareness Week, Dr. Gargiulo from Brigham and Women's and Harvard University and Dr. Vidali will join Resolve New England to have an entire infertility discussion. And we may or may not discuss the COVID controversy. And then on Wednesday, April 29th, time to be determined, we will do the infertility reproductive immunology celebration of Dr. Braverman's life, as it will have been 1 year since his passing. So we will see all of you for all those other amazing events. Please follow Dr. Arrington. You want to tell everybody your social media handles? Go, Dr. Arrington.
I don't know if I can remember him. Jeff Arrington, endosurgeon, is my Facebook. Social, I can't remember what the Instagram is. If you search my name,
it's Dr.Jeff_endosurgeon.
That's the Facebook, right?
No, this is your Instagram.
Okay.
Dr.Jeff_endosurgeon. You really went for a simple one, Jeff.
No.
And also, we invite you to follow Center for Endometriosis Care on all their platforms. We want to congratulate Dr. Andrea Vidali, a very important milestone. He reached his swipe up for his 10K on Instagram. And also, the Endometriosis Summit can now be found on TikTok. And tomorrow I'll make a total fool of myself again. I have given Dr. Vidali the password, so we'll see what he comes up with.
Those dances.
He's been dancing. He's been, you know, we'll see. It'll be great. It's all probably to Italian pop. That probably,
right.
Yeah. And we'll see you right back here on Monday evening at 8 p.m. Eastern Standard Time. Take care.
Thanks, everybody. Bye, Jeff.